Good afternoon, everyone. I would like to welcome you to the last session of this year of CME series on lysosomal disorders. And today we're going to be discussing the immune system and its relevance to the patients and the disorders for lysosomal disorders. So these are my disclosures, and I am your host, Ozlem Goker-Alpan, the founder and director of Lysosomal and Rare Disorders Research and Treatment Center. So for today's lecture, we're going to be reviewing how the immune system is involved in lysosomal storage disorders, review the pathophysiology of the immune response reactions, and describe how to better manage the patients with IRRs, and also describe the best clinical practices to monitor the patients with immune response reactions. So to start with, let's start with the lysosome. Obviously, there are multiple functions of the lysosome, but many of those are either directly or indirectly are related to the immune system, such as the cell migration, tumor invasion, and metastasis, metabolic signaling, and the cell death, gene regulation, autophagy, and directly involvement with the immune system. So the direct functions that it relates to the immune system is the microbial killing, antigen presentation, and survival of the immune cells through the autophagy process. Just to reiterate, the innate and adaptive immunity, the T cell, the NKT cell are in the middle. And the macrophages, actually, they are the cells in the tissues that tie these two systems together. Activated macrophages are hallmark of many lysosomal disorders, but obviously they are truly the pathognomonic for Gaucher disease. We call them actually Gaucher cells. So Gaucher cells found in the tissues, they can present as multinucleated cells with a fluorescent cytoplasm, but literally they are activated macrophages that secrete many chemokines and cytokines. So the biomarkers of macrophage activation, in addition to Gaucher disease, can be found in many disorders to varying degrees. To name few is Niemann-Pick A and B and C, Fabry disease, cystinosis, so on and so forth. So chitotriosidase is an enzyme that is selectively secreted by the activated in tissue macrophages, and actually we use chitotriosidase as a disease activity marker in Gaucher disease. So alteration of macrophage cell function impairs the innate immune system and then increases the levels of pro-inflammatory response, including the chemokines and cytokines. And macrophages actually can release the partially digested soluble material that is substrate or the cells containing the substrate through a process called autophagy. And autophagy is more active in pro-inflammatory macrophages and also induced by the toll-like receptors. So when we look at the markers of the, such as the substrate markers, in this slide, we are actually providing an example of lyso-Gb1, which is the glucosylsphingosine, is the deacylated form glucosylceramide. As one might remember, glucosylsphingosine is a quite inflammatory molecule. And in this slide, what you're seeing is the patients with lyso-Gl1 or lyso-Gb1 levels, actually, they correlate with the macrophage activation marker or chitotriosidase. However, there is a small subset of patients, even though the disease is controlled in these patients, that can be reflected by the lyso-Gl1 or lyso-Gb1 levels close to normalization or stabilization. Still, in these patients, actually, chitotriosidase levels could be elevated, which indicates that the inflammatory or the immune response to the stored substrate actually moves the disease forward, causing a downstream pathways to get activated. So in the plasma, we can find the derivatives of the substrate, and these can actually further the inflammatory reaction and with activation of the B cells, T cells, and obviously the dendritic or the antigen presenting cells, and which leads to formation of antibodies and the other response that is responsible from the inflammatory pathway that goes to fibrosis, cell death, and activation of other immune pathways such as complement system. So we can give an example to the humoral response, as is deficiency in Gaucher disease, as you see in slide, or the persistent alterations that we may see in the patients with Fabry disease. So as I reiterated in the previous few slides, that is the immune system involvement further self-propagates the disease state, which could be independent from the initiating event. And the therapy, depending on when it was started and the disease activity or disease state when it was started, can only partially rescue this immune dysregulation. So what we had done is we had looked at the patients who started treatment with Gaucher disease, who started treatment either delayed and with the disease activity, and then we see B cell alterations, and then we say significant antigen presenting cell alterations and the cells with IgA, IgBP positive cells. When we look at the delayed treatment, which is 20 years or more after the start of the symptoms that we actually have seen in patients before the advent of therapy. That is basically then when you see these, the immune system remains activated despite of therapy. So the last slide of this introduction is obviously we had talked about in the previous session in detail about the complement system and the complications that may present with the complement activation, but the complement also is activated in certain disorders, including Gaucher disease, to assert that's increase the substrate levels that can be measured. So the other response that can occur in addition to the actual pathology of the disease is the response to the therapeutic proteins. We're discussing here enzyme replacement therapy, and this can be either in the formation of antibodies or the immune response reactions or immune hypersensitivity reactions. So there are multiple factors that can affect the immune response, which could include the molecular defect, the immune competency, age, gender, but the most important one is among those is what we have seen is the pro-inflammatory status of the disease or the patient. So these two examples are, one is the Gaucher disease, which there is only a small subset of patients develop antibodies to the therapeutic protein. In the other end is the infantile onset Pompe disease. Almost every single patient develop antibodies, and that hampers the treatment efficacy. So in the previous slide is here, we are talking about a little bit about the infusion-related reaction or immune hypersensitivity reactions, which can be related to the response to develop antibodies to the therapeutic protein, but in our experience, it is true unrelated, which means that the patients may not have antibodies or may have low titer antibodies, but they may have significant infusion-related reactions and to the infused protein, and one example to that is Fabry disease. And similar to the risk factors that is we discuss in the development of antibodies to the therapeutic protein, other factors that could be actually playing a role in the IHRs or IRRs is the pro-inflammatory state, personal history of allergy to excipients, dose, age, gender, and how the product is administered. So it's similar in the slide is actually the prolonged inflammatory state is an important factor in Fabry disease and the infusion-related reactions. So after this introduction, I would like to invite Dr. Goker-Alpan, who is the director and the CEO of Amerimmune. Amerimmune is a group of companies that was actually established by Dr. Alpan and whose mission is to innovate the diagnosis, research, and therapies in immune and allergic disorders. Briefly, Dr. Alpan, after completion of his pediatric residency, after he received an award of research excellence in pediatrics by the National Institutes of Health, he started his fellowship at the National Institutes of Allergy and Immunologic Disorder, Infectious Disease, where after 3 years of training in the clinical program, he spent few more years at laboratory of cellular and molecular immunology. So with this point on, I would like to invite Dr. Alpan for the rest of the presentation. Thank you.
So I was asked today to talk about the immune system and how it relates to drug reactions and immune response to the medications that are used in not just lysosomal storage disorders, but in any setting where a drug reaction is involved. So the title of my presentation is Introduction to Immune Pathways and Immune Response to Therapy in Lysosomal Storage Disorders. I have no reportable conflicts of interest, and this disclosure was presented before. I will be receiving an honorarium and a travel grant from Sanofi Genzyme, and I will make disclosures when a product is discussed for any unapproved use. And thank you for Sanofi, Takeda, and Chiesi for their educational support for this educational activity. The learning objectives for today is to review drug reactions and how it relates to the immune system, discuss about the process of inflammatory cell death, discuss the diagnostic approach to suspected drug hypersensitivity, and also describe the factors that influence drug reactions. So just as an introduction, what do we mean by an adverse drug reaction? So an adverse drug reaction is any undesirable effect of a drug beyond its anticipated treatment effects occurring during its clinical use. And so this includes everything that you see at the time of the use of a drug. It's a major issue because adverse drug reactions are a major problem, accounting for a significant percentage of all hospital admissions. And not just hospital admissions, but they're also seen in the course of a hospital admission when a patient is being treated, as well as in the outpatient setting. Now, if we classify drug reactions under two big umbrellas, one of them is pharmacological drug reactions. So the simplest example to this would be in the setting of an allergic condition, an asthmatic. If they're using an inhaler, one of the side effects of the inhaler, a short-acting beta agonist inhaler, is to increase the heart rate. So this is not an allergic reaction, but it's a pharmacological reaction to the drug. It is generally anticipated, and it has to do with the mechanism of action of the drug. So that's why it's called a pharmacological adverse reaction. Now, we will not be focusing on these today. We're going to be focusing on more what we call type B, idiosyncratic. So these are reactions that we typically do not expect to see and has not much relationship to the drug's mechanism of action. These are reactions that create problems in the management of patients. A lot of these type B reactions are thought to be mediated by the immune system, but a certain portion of them aren't. But when we say the immune system, it's a huge umbrella. So one of the things that I would like to do today is to sort of dissect out what we mean by the immune system, because it's going to also impact how we approach to these patients diagnostically, and it's going to impact our thinking on how to manage these reactions. Dr. Goker gave a very insightful presentation on the mechanism of disease in lysosomal storage disorders. So when we're talking about idiosyncratic allergic and immunological reactions to drug, it's not just the drug that matters, but the condition of the host is also important, whether the host is in an active inflammatory state, whether there's any other immune reactions happening in the host. They all determine the outcome and the type of idiosyncratic and immune reactions. So sometimes the disease is relevant, and sometimes it isn't, to the underlying immune response that happens from the use of a medication. So these are all factors that one needs to consider. So let's first start by looking at what some of the cells of the immune system are and how they relate to adverse reactions to drugs. So if we were to categorize immune cells, they fall into two separate buckets. So one of them is what we call innate immune cells, and the other is adaptive immune cells. So innate immune cells, by definition, are there to respond to things, whether they're pathogens, whether they're drugs, immediately, without an education process that has to go through for them to learn how to respond. So there's a number of cells that are under this category. The first one is, in no order of importance, is the eosinophil. Eosinophils are classical allergic cells, typically increase in the blood counts of patients who have allergic disorders like asthma, allergies, etc. They usually function by attacking allergens directly, or sometimes they could attack pathogens directly, such as in parasites. And they are a very important component of an allergic reaction to a drug. And as a matter of fact, when patients present to physicians with questionable allergic reactions, let's say with a skin rash, when a skin biopsy is performed to look at what cells are involved, the classification of an allergic reaction is done when these cells are seen in a biopsy specimen. So they're very, very important, not just in the pathology and the pathogenesis of a drug reaction, but also in diagnosis when they're seen in either the blood sample or in a tissue sample. The second cell is the mast cell. These are very rare in the bloodstream. They're mostly found in tissues, and they carry a molecule called histamine, among other things. And histamine is a molecule that causes the classical itching that we see in allergic drug reactions. Histamine is a molecule that causes blood vessels to dilate and become leaky. And that's one of the reasons why it will cause some of the swelling reactions we see in drug reactions. The next cell is the basophil. So basophil, we could look at it as the mast cell counterpart that circulates in the bloodstream. These are also important cells to identify. One of the things that happens, let's say in an acute anaphylactic reactions, is that these cells disappear from the bloodstream. It's classical sign of an anaphylactic reaction. One of the usefulness of the basophil is in a test called the basophil activation test. We sometimes use that assay to test if a patient has an immediate hypersensitivity to a drug, and it's a test that's done on a blood sample of a patient. The next cell is a dendritic cell. So these are also called professional antigen presenting cells. They play a very important role in inducing the immune response to drugs as well as other things. They sort of act as the bridge between the innate immune system and the adaptive immune system, which I'm going to get into in a few seconds. The next cell is the monocytes. These also circulate in the bloodstream. We usually look at them as the scavenger cells. They collect garbage from blood vessels or tissues, and they kind of carry it from one side to another. They don't really play a role in initiating an immune response, but their increased levels in the blood is also a very good indication of an inflammatory response. Dr. Goker mentioned about inflammation that's seen in Gaucher disease and other lysosomal storage disorders. She mentioned about a cell called a macrophage. So monocyte is, in a way, the cell that is reflective of a macrophage that could be seen in the bloodstream. Macrophages are more confined to tissues. And finally, another innate immune system cell is the natural killer cell. These cells play a lesser role in drug reactions. Their main goal is to identify mostly virally infected cells to tell the immune system to start fighting against pathogens. Now, the adaptive immune cells, there's two major components to it. And as I said, the dendritic cell sort of provides the bridge between these innate and the adaptive components. So one of the adaptive immune system cells, and we all hear about antibodies, is the B cells. B cells make antibodies. They play a role in not just drug reactions, but they also play a role in producing antibodies, which we will hear about, neutralizing antibodies, in inducing antibodies against drugs to render them less effective. The other cell that plays an important role in the adaptive immune system is the T cell. T cells function in cellular immunity. They don't make antibodies, but they usually cause damage to tissue cells directly by engaging with them by cell-to-cell contact. As you could see, all of these cells have different functions. They interact with each other, so they don't function on their own, and they cause distinct pathologies. So when we're talking about looking at a blood sample, looking at a tissue sample, identification of what cell is playing a role in a specific drug reaction allows us to understand the nature of the drug reaction, but it also allows us to design treatments geared towards them. I mentioned a bit about the professional antigen presenting cell. I mentioned that the dendritic cells are the primary professional antigen presenting cells, and these are nice images of them, as you could see here, done by either scanning electron microscopy or an H&E staining that shows the typical sort of structural characteristics of this cell. There's also two other cells that play a role in antigen presentation, but they're not professional antigen presenting cells, and those are the macrophages, which engulf drug molecules or other immunogens and pathogens and present it to the immune system, as well as B cells that make antibodies that could also act as antigen presenting cells in induction of an immune response. So I'm going to go through some of these statements that I mentioned one by one to give a little bit more clarity. So we discussed about antibodies. Antibodies circulate in the bloodstream. They also go into tissues. They're primarily made by plasma cells and B cells. B cells do not make antibodies on their own. They need help from T cells. So I discussed at the beginning of my presentation that a lot of these cells interact with each other. They don't function individually. So here's an example of a cell, B cell, that makes antibody that requires T cell help to do so. The primary role of antibodies is to prevent infections, but in certain cases, they could also enhance infections if antibodies are used as sort of Trojan horses for pathogens to get inside cells. They're mainly made against pathogens, but they could be made against anything that comes into the body. In this case, drugs, right? So they could be made against drugs and cause problems, such as an IgE antibody made against a drug that could cause an allergic reaction. But they could also be made against drugs, such as an IgG type antibody that could prevent the efficacy of the drug. They could cause autoimmune disease, they could cause anaphylactic reactions, and they could also participate in inflammatory reactions. We talked about antigen-presenting cells, and the dendritic cells are what we call the professional antigen-presenting cells. So to initiate an immune response for the very first time, the antigen has to go through the dendritic cell, whether it's a drug antigen or whether it's a pathogen. B cells, monocytes, and macrophages are non-professional antigen-presenting cells. So once the immune system is trained to react to a pathogen or a drug, these cells can now take over and sort of boost up the immunity towards the pathogen or the drug. Antigen-presenting cells can present drug antigens to immune cells, but they could also become activated by them. And more importantly, they could participate in the inflammatory reaction. So once these cells starts to participate in the inflammatory reaction, then that also sometimes allows us to design certain therapies to eradicate the drug reaction. The next system that I want to talk briefly about is the complement system. I didn't mention this initially, but the complement system is present in the soluble part of the immune system. These are not cells, but they allow cells to interact with each other. They are a central component of the innate immune system, but they do bridge the innate immune system to the adaptive immune response. They're important because they can be activated in drug reactions, but there's also several drugs like intravenous immunoglobulins, which have dampening effect on the complement activation. The nice thing about the complement is there's many different blood tests that could be done to detect different complement components, which will give us an idea about the nature of the drug reaction that's happening. And finally, there is a form of cell death that happens in our body, whether it be from an infection or a drug, called inflammatory cell death. We've all heard about apoptosis. So apoptosis is controlled cell death. It happens in our bodies every day. Cells die, they shrink, and they get scavenged by monocytes and scavenger cells and are sort of destroyed. But there are also forms of cell death that happens, again, both from infections and with drugs that are inflammatory in nature, meaning rather than the cells being scavenged and put away, cells burst open and they cause an immune response. The classical one is pyroptosis. This is a form of cell death that not only destroys the cells, but also induces immunity at the same time. We heard about cytokine storm a lot at the onset of the COVID-19 pandemic. And pyroptosis is a process that also leads to cytokine storm, but it's also seen in drug reactions too. Necroptosis is another form of inflammatory cell death. As you could see from its name, necrosis can't be a good thing, but these are all things that that activate the immune system in a way that would result in inflammation. These types of cell death can be measured. They're measurable. There's blood tests that do that, but there are no specific drugs that are direct inhibitors that have been approved by the FDA at the present time. Now, we talked about inflammatory cell death, and I think this is very, very important because one of the side effects of drugs can be damage on the tissue. And that is how an immune response gets started. So a drug, a pathogen doesn't directly go and tell the immune system to start making an immune response. It happens after a damage happens to a tissue cell. This is also known as the danger hypothesis too. So the tissues send alarm signals to the immune system, specifically to the professional antigen presenting cells. In this case, these are dendritic cells. And those cells in turn activate the lymphocytes to induce an immune response. So what are these alarm signals? There are a number of them. They're not just one. And usually these are things that are found inside the cell. So when a tissue is destroyed, it releases things that are found inside the cell to the exterior. And those are the molecules that will activate the antigen presenting cells. So just to give an example, heat shock proteins are one of them, uric acid. ATP that's found inside the cells is a big line item once it becomes extracellular, and a number of other items that you see on this slide that play a role. So here is a classical immune mediated drug reaction that is triggered by an antigen presenting cell resulting from tissue destruction that activates the T cell. Here is the clinical presentation, a very diffuse rash in a patient all over the body. And when a skin biopsy is performed, cytotoxic T cells can be identified in the biopsy specimen, which gives us an idea about the mechanism of the drug reaction. Now I'm going to get into some of the key features on how to approach patients with drug reactions, and this involves history taking. This involves timing of the drug reactions. These are all very, very important. These are not just limited to lysosomal storage disorders, but applies to any kind of a disease and any kind of a drug reaction. And I think these are very important in how to approach a patient who has a drug reaction. So the first one is the timing, right? So some drug reactions are immediate, meaning the drug is administered and within seconds, minutes, within hours, patient gets a reaction. So those are called immediate drug reactions. They could be anaphylactic in nature, and they could be non-anaphylactic in nature. By definition, an anaphylactic drug reaction is one that involves multiple organ systems and typically is mediated by IgE. So meaning a drug that is administered to a patient, the patient starts wheezing, that means the lung is involved and has hives all over the body. That's a classical anaphylactic reaction. Immediate reactions that are non-anaphylactic can still happen quite rapidly, but generally does not involve multiple organ systems. A classical example for this is hives. You administer a drug underneath the skin by injection. This could be, for example, a vaccine, and you see hives at the site of the administration, and that's involving one organ system. In this case, it's skin, and it's localized. Hence, it's not an anaphylactic reaction. The second group of drug reactions are delayed, so they don't happen right away. They happen either hours later or days later. So those are called delayed drug reactions. It's important to distinguish these two because their mechanism of actions are different, and the classification becomes different, and the management of these reactions then become different. So what are some of the factors that influence these drug reactions? One of them is more specific to the drug itself. Is it a protein? Is it a lipid? Is it a peptide? Is it a small molecule? Is it an antibody? All of these play a role in the type of reaction that we get to a drug. The second one is the dose, right? So dose is important because there will be patients that have adverse reactions to drug only after a certain dose. And that's important to understand because sometimes that will allow us to dose the drug differently to be able to administer to the patient. So every time you are encountered with an adverse drug reaction, it becomes important to ask about the dose. The third one is the rate of administration. We see that with mostly intravenous drugs. Sometimes when they're administered super fast, patients will react to it. And when I mean react, these could be an immunological reaction or a non-immunological reaction. So that's also important to identify because a simple adjustment in the rate of administration can be the solution to the problem. And the final one is the duration of use. So this is also important because if you're encountered with a patient that has been on a medication for a full year and then they started having reactions to it, it generally makes us think away from an allergic reaction. It could still be an immune-mediated reaction to the drug, but allergic reactions become less likely. So again, the duration of use becomes important in our thinking in understanding what the mechanism of it and how to manage these patients. We talked about types of drug reactions. This is going a little bit more detail into it. We talked about the type B, which is the hypersensitivity reactions. Again, hypersensitivity reactions can be a super immediate reaction that is IgE mediated, or they could be slightly delayed where they're IgG mediated. It could be related to a cytokine release syndrome. It's a type alpha reaction. Again, immune and cytokine imbalance syndromes, such as impaired immune function and immunodeficiency state, can impact a drug reaction. And Dr. Goker mentioned in his introduction speech, patients with lysosomal storage disorders have a baseline hyperactivated immune system. So these become a significant important factor in evaluating patients with various diseases and how they react to drugs. Cross-reactivity becomes important, such as you may be allergic to, a patient might be allergic to penicillin, and they will have cross-reactivity to certain other drugs, such as cephalosporins, and this plays an important role in guiding patients. And again, as I mentioned at the beginning of my presentation, there's non-immunological side effects to medications. Now, we talked about cytokine release. It is not a single mechanistic event. There's different ways cytokine release can happen. It could happen because of activation of a cell. It could happen because of a complement-mediated lysis of cells. I mentioned about complements being the sort of bridge between adaptive and the innate and the adaptive immune system. So they could act as sort of envoys to lead to cytokine release. The cytokine release can happen because of direct apoptosis or inflammatory cell death. This is also important to identify. And finally, the cell that I mentioned, the natural killer cell at the beginning of my conversation, can cause an antibody-dependent cellular cytotoxicity and cytokine release. So these are important because a lot of these are detectable by a number of tests for us to understand the mechanism of the drug reaction so we could design treatments accordingly. Now, I also mentioned about time. This is also very important. For example, reactions that happen within an hour, and in rare cases up to 12 hours after exposure, are usually in the sense of hives, asthma, and anaphylaxis. So these are how these patients manifest. Patients who present with a maculopapular drug rash that's not urticarial in nature, they typically happen 4 to 14 days after the start of use of a medication. And that also puts our thinking in a different direction. And then there's other forms of drug reactions that either happen 1 to 12 days after, 4 to 28 days after, and many days after, 2 to 8 weeks after the start of the use of a drug, such as in DRESS syndrome, or in Stevens-Johnson syndrome, toxic epidermal necrolysis. A lot of these reactions start later in the course of the use of a drug. Their mechanisms are different. Cells that are involved in causing these reactions are different, and the treatment approaches to these are very different. For example, in a very acute reaction, we might be using antihistamines to deal with the allergic reaction. However, when the reactions become much later in the course of a drug use, then antihistamines become less effective, and we need to revert to other measures of treatment modalities. So what is the diagnostic approach in a patient with a suspected drug hypersensitivity? As I said, assessment of history and symptoms are very, very important. So if it's unlikely to be a drug reaction based on the history, then there's no allergy diagnostic workup that needs to be done. But if it's possible or likely that the person is experiencing a drug reaction, and then the question becomes, are there tests that are available to diagnose this? In some conditions, there are tests available. The classical example is penicillin. There's skin tests and blood tests that are available. So we could test the patient, and if it's positive, we could confirm the drug hypersensitivity. However, in many cases, there are no tests that are available to diagnose the drug allergy. In that case, then we start asking the question, is a provocation needed? Sometimes it can be done. The provocation test is performed, and if it's negative, the drug hypersensitivity is ruled out. And if it's positive, and the drug hypersensitivity is ruled in. And in some cases, the provocation is not possible. So in that case, we talk about a possible drug reaction, we document the reaction, and we recommend the patient avoidance. Unfortunately, drug allergies is not an area that extensive research has been done. Therefore, that's one reason why skin testing and laboratory tests are less available for drug reactions compared to other areas of immunology. Therefore, history taking, the timing of the reactions, the nature of the reactions, biopsy samples, if they're obtained, are some measures that are used to diagnose these patients become very, very important. Now, what are some of the tests that we use? For immediate drug reactions, there are specific IgE assays that could be used. A classical example for this is penicillin allergy, again. There are other tests that have usage, such as the basophil activation test. This can be done on a blood sample. This allows for a lot more drugs to be used in the testing compared to specific IgE assays. The basophil activation test's principle is based on incubating the peripheral blood basophils with the offending drug antigen to see if the basophils upregulate certain markers on their surface. In labs that are able to do this, and if the tests are validated, these can be fairly useful tests to identify a drug allergy. There are also in vivo tests one could use. Skin test is one of them. And again, the classical one is for penicillin allergy. For those skin tests that are not available, then one can consider provocation. Again, provocations are done in controlled environments, assuming the patients may have an adverse allergic reaction to the drug. The rest that are seen under this non-immediate are sort of questionable tests. They're not done very often. And they're looking at the patient's T cells to see if the drug in a test tube alters the T cells or activates them. There are ELISpot assays, again, looking for whether when the drug is incubated with the cells release cytokines, and those can be measured in vitro. There could be in vivo tests, such as allergy testing with delayed intradermal testing, patch testing, provocation testing. All of these can be done, but in the when we have negative results with these tests, since they're not very validated testing, it's hard to rule out. If we have a positive result, then they have some meaning that could be applied into clinical care. Now, one thing I want to point out here is we all hear about desensitization in drug allergies. The primary one we've always used this as an allergist, immunologist, is to do penicillin desensitization. So this only causes temporary clinical tolerance. Desensitization does not induce long-lasting immunity. So it works for the duration of its use. So meaning, if you have a patient, you want to administer a drug, you know the patient is allergic to the drug, and you want to induce a temporary clinical tolerance so the drug can be given for a certain amount of time, that's when the desensitization becomes useful. In general, it's only effective in immediate reactions. So meaning, if a patient presents with a reaction that happened 3 weeks later, those are patients that generally don't respond to desensitization. Now, We talked about immediate reactions. It does not need to be IgE mediated. So we talked about immediate reactions being IgE mediated or non-IgE mediated, but most immediate drug reactions can go through a desensitization process. And the protocols vary for drugs and between institutions. So every institution has their own protocol on how this is done. Another classical one for desensitization, again, we talked about non-IgE, is aspirin desensitization, for example, in patients who have sensitivity to such drugs. Dr. Goker, in her closing statements, may touch a little bit on this issue. Again, we talked about drug reactions in my presentation, but sometimes these drug reactions present in the form of neutralizing antibodies. So it may not be visible as a skin reaction and a lung reaction, an asthma reaction, but it could manifest itself as a neutralizing antibody where the drug stops working. This could also be considered as an adverse drug effect. And you could see this can be seen in multiple different types of lysosomal storage diseases, Gaucher disease, Fabry disease. And every time a drug is administered in a disease state where the enzyme is missing, the body starts to see that drug as foreign, and it'll make an immune response to it. And that's the basis of the neutralization that we see in this case. When we are encountered in a situation where neutralizing antibodies are formed, then the approach to dealing with that becomes a little bit different. You could see on the right side of the slide, we don't see anything as desensitization. All you're seeing is drugs that are used that are immunosuppressants. And the reason for that can be seen in this slide, that medications like methotrexate, rituximab, and the others that I've shown you in the prior slide act against different components of the immune system that I presented to you at the beginning of my presentation, such as the antigen-presenting cell, educating the T cell to make an immune response, and the T cell helping the B cell to making antibodies. So any drug that intervenes and blocks these cells to function by making antibodies, again, may be useful in decreasing the immune response so that the neutralizing antibody levels also decrease. So in summary, I tried to give you an overall sort of basis of how we look at drug reactions. As you could see, many factors play a role. History becomes super important. The timing becomes very important, and the nature of the drug reaction becomes very important. Understanding how to classify these. As you could see, there's no one-shoe-fits-all approach to this. Identification of the potential mechanisms impacts treatment approaches. I talked about desensitization. I talked about neutralizing antibodies. So understanding the mechanism that is underlying the reaction to the drug, whether by in vitro tests, such as measurement of IgE antibodies, basophil activation test, or in vivo assays, such as skin testing, provocation tests become very, very important. And also, at the end, it's also important to understand there's a difference between a naive and an educated immune system, and how these immune system components respond to a drug is a critical factor in our approach to treating patients with drug reactions. So I'm going to thank you for listening to me, and I will pass the podium to Dr. Goker so she could make some concluding remarks here.
Thank you, Dr. Alpan, for this very, actually, I wish that we did this lecture way before. The reason is you made the things